My name is Bozena Morawski, and I'm here with Chris Johnson. Chris, you want to come over and wave to the camera? We're presenting from the same machine today, remotely, but together. So we'll be presenting Idaho's Cancer Survivors, Insights, and Needs, and both of us are epidemiologists at the Cancer Data Registry of Idaho, which is a program of the Idaho Hospital Association. And we'll be kicking it off with some information about Idaho's cancer survivors. So just an acknowledgement and disclaimer. So this project has been funded in whole or part with federal funds from the National Cancer Institute and the Centers for Disease Control and Prevention. However, the findings and conclusions in this report are ours alone and do not represent the official position of CDC or NCI. So the learning objectives for today for you all is one, to understand the burden of cancer in Idaho. We recognize that you have experiences in your own specific facilities and practices, but we wanted to give you an overall picture of what things look like in the state. And then second, to understand specific characteristics of and challenges experienced by Idaho's cancer survivors. And this will represent, or what we're presenting today will probably represent a very small fraction of the cancer survivor experience, but it's what we had data to support. So that's why we chose to talk about the things that we chose to talk about. And three, we want to just teach you a little bit about sources of population level cancer survivorship data, should you have any data needs moving forward. So to set the stage, Idaho has one of the lower cancer rates among the US states, in part due to lower smoking rates, lower alcohol consumption, and lower obesity rates than other US states. We're not the lowest, but in the lower tertile, or one of the second to lowest quartile. And these data are from CDC and they're from 2018 to 2022. That said, in 2023, over 10,500 malignant tumors were diagnosed among Idaho's residents for a rate of 446.9 tumors per 100,000 population. As you can see from this map showing age-adjusted rates by county, there's a lot of variability in cancer incidence in Idaho. The number of cancer survivors living in Idaho has increased by 23% in the past 5 years. So from 45,000 in 2018 to 54,000 in 2023. This is primarily due to increased population and increased longevity post-diagnosis related to improvements in treatment and increased access to affordable health care. As of July 1st in 2023, 1 in 36 Idahoans were estimated to be living with a cancer diagnosis that they had received in the past 10 years. Of note, this does not include basal and squamous cell carcinomas, which are not reportable to the Idaho Cancer Registry or any cancer registry nationally, and would approximately double the number of incident cancers each year. At that same time, July 1st of 2023, over 16,000 Idahoans were estimated to be living with a cancer diagnosis that they received in the past 2 years. And we bring this up because this is a time period during which many of these patients may still be receiving treatment. Excuse me. This slide shows the distribution and counts of these tumors, with breast, prostate, melanoma, lung and bronchus, colorectal, and bladder being among the most common, shown on the left. However, other primary sites account for nearly 1 in 3 diagnoses, which are shown in the pie chart to the right, and demonstrate the diverse cancer survivor population in the state with respect to treatments, sequelae, medical costs, and other factors. So before we move on to talk about the experience or some aspects of the cancer survivor experience, we wanted to provide additional information about the source of these data, the Cancer Data Registry of Idaho. So CDRI has been a program of the Idaho Hospital Association since 1969 and has contracted with the state of Idaho to run the state's population-based central cancer registry since 1971, making it one of the oldest in the country. CDRI collects data on all cancers diagnosed among Idaho resident patients, even those that are treated out of state, and non-residents diagnosed or treated for cancer in Idaho. CDRI collects extensive information characterizing reportable tumors and associated therapy, patient demographics, and long-term vital status. And for more information about the cancer registry, please contact your presenters, me and Chris, and our emails will be listed at the end of this slide show as well. So moving on to the experience of Idaho's cancer survivors. A 2024 report identified cancer survivor needs and resource gaps in Idaho, highlighting 5 key findings that are listed here. We plan to present data related to the first 2 points highlighted here, that mental health was a top concern for cancer survivors, and that survivors struggle to find the financial resources, struggle with the financial burden of survivorship. And as I mentioned before, we selected these points to talk about primarily because we have data that can characterize these specific elements of cancer survivorship. As we go through the following statistics, we ask that you keep in mind that the age distribution of cancer survivors is much older than the general population, with 2 in 3 being 65 or older. This will be important when we compare the experiences of cancer survivors to the general population, as the estimates are influenced by the underlying age distributions of each group. Because of this, we will show crude and age-adjusted estimates as they offer different insights into survivor needs. As a reminder, crude proportions are an absolute proportion of people who are experiencing a condition and represent burden in a more straightforward way. And age-adjusted proportions are standardized to a uniform age distribution and allow us to compare statistics across what otherwise may be apples and oranges. So this slide shows the crude, i.e. the actual burden, of cancer survivors in light blue compared to Idahoans who have never been diagnosed with cancer in dark blue. Shown on the left is the proportion of Idahoans that did not seek needed medical care due to cost. Among Idaho cancer survivors, this number is nearly 1 in 10. On the right, we see that 3 in 100 cancer survivors reported not having healthcare coverage, which is less than the nearly 9 in 100 among those who have never been diagnosed with cancer in Idaho. And this color scheme will carry throughout the slides, with light blue representing Idahoans with a cancer diagnosis in the past 10 years and dark blue representing the general population. So, however, and this gets to the piece about the underlying age structure of cancer survivors versus the general public, when adjusting for age, survivors are 2.5 times more likely to not seek needed medical care due to cost than non-cancer survivors. Furthermore, insurance coverage estimates between survivors and the general public become more comparable, with about 9% not having coverage in both groups. Here, we see crude and age stratified estimates of barriers to medical care related to cost. And note that differences between the crude and age-adjusted estimates that we saw earlier are primarily driven by the proportion of cancer survivors under 65 years of age. Younger patients were 6 times more likely to not seek needed medical care due to cost, with 16.8% of cancer survivors under 65 years not seeking medical care due to cost versus 2.6% of those age 65 and older. This map shows the crude prevalence of adults with a cancer diagnosis that did not seek needed medical care due to cost by public health district or region in Idaho. We again note that there is a lot of variability across the state, and that southeastern Idaho, which also has a younger population, has the highest rates of adults struggling with medical care costs. This slide shows age-adjusted rates, which are again not representative of the absolute burden, but show that adjusted for age, Idaho cancer survivors are more likely to abuse alcohol and use tobacco products than those without cancer. These results are similar to what we see in other states and in the literature, and are related to pre-diagnosis risk behaviors in the cancer survivor population. So on the x-axis to the left here, we have heavy drinking, binge drinking, current nicotine use, current cigarette smoker, and current e-cigarette user. And e-cigarettes are pretty comparable in the survivor versus non-survivor groups, but for all the other categories, the proportion or prevalence of adults using these substances or falling into these categories is much higher than the non-survivors. Reinforcing the results of the 2024 Idaho Cancer Survivor Needs Assessment, Idaho's cancer survivors are more likely to report poor mental health and poor physical health relative to Idahoans who have never been diagnosed with cancer when adjusting for age. These results also tie into the final section of this presentation, which is the results of a study related to deaths of despair in Idaho's cancer survivors. But first, we wanted to provide you with some additional information on the survey data presented in this section. So these data are from the Idaho Behavioral Risk Factor Surveillance System, or BRFIS survey, which is housed at the Idaho Department of Health and Welfare. BRFIS conducts telephone surveys to collect data on health-related risk behaviors, chronic health conditions, healthcare access, and use of preventative services among U.S. residents. BRFIS is a National Centers for Disease Control and Prevention, or CDC program, but it is administered at the state level. And if you're interested in more information about BRFIS, please contact Chris Murphy, the director of Idaho BRFIS, and Jonas Frankel-Bicker, who provided the data in this presentation. And we really appreciate their partnership. So now I'm going to hand it over to Chris to talk about this final aspect of this presentation.
Okay, the final topic that we're going to cover is what cancer patients die of besides cancer. So we're going to briefly present a study of deaths of despair, and that term, deaths of despair, was coined after a 2015 study by two Princeton economists, and they showed that midlife mortality rates among Americans were increasing, and that's different from what was seen in other high-income nations. And it was due to suicide, overdose, and chronic drug and alcohol use. This is some background on why we chose this topic. A diagnosis of cancer can elicit significant psychological distress. Psychological distress may be linked to deaths of despair among cancer patients, and there is little research published on the topic. This is the question we're trying to answer, which is, are Idaho's cancer survivors dying of deaths of despair at higher rates than their cancer-free peers? And for this study, we looked at Idaho cancer cases diagnosed in 2016 to 2022. That included about 62,000 patients. And then using underlying cause of death codes from death certificates, we identified deaths of despair among cancer patients and the overall Idaho population. This slide shows the ICD-10 codes for overdose, suicide, and alcoholic liver disease and cirrhosis. We calculated standardized mortality ratio statistics for Idaho cancer patients compared to all Idahoans, and we calculated these SMRs for both the pre-pandemic and pandemic time periods. During the period 2016 to 2022, there were 19,440 deaths among the Idaho cancer patient cohort, and 213 of these deaths were deaths of despair. You can look at how they compare to other causes. So the vast majority were malignant cancer deaths. Other large categories were heart disease, but there were actually more deaths of despair than there were deaths from diabetes and Alzheimer's, and similar numbers to stroke. This graph shows point estimates in red and 95% confidence intervals in black for the standardized mortality ratios, or SMRs, that compare the Idaho cancer patient cohort to the referent rates for all Idaho mortality. And there's a horizontal line drawn at SMR equals 1. So an SMR of 1 would mean the rates for the cancer patient cohort are the same as the background Idaho rates. When the confidence interval does not cross 1, we deem that a statistically significant SMR. As you can see, Idaho cancer patients had significantly higher mortality from deaths of despair overall and in the pre-pandemic and pandemic eras. This slide shows results for two of the three types of deaths of despair: suicide and alcoholic liver disease and cirrhosis. Overdose was not a primary driver of deaths of despair for cancer patients. So on the left-hand side is a graph for suicide. Compared to all Idahoans, Idaho cancer patients are at higher risk for suicide. The SMR for Idaho cancer patients for suicide increased from the pre-pandemic to pandemic eras for both males and females. And on the right-hand side is a graph for alcoholic liver disease and cirrhosis. Compared to all Idahoans, Idaho cancer patients are at higher risk for alcohol-related deaths. The SMR for Idaho cancer patients decreased from the pre-pandemic to pandemic eras for both males and females. So this is key points from the whole presentation, not just what I spoke about. So Idaho's cancer survivor population is growing and living longer. They have unique needs. Idaho's cancer survivors experience financial hardship. They disproportionately experience cost-related difficulty in accessing needed medical care. They may benefit from increased tobacco cessation and alcohol reduction efforts, and they experience significant mental health challenges. So thank you. And I don't know if we want to open for questions or put it towards the end. So,
Bozena and Chris, thank you so much. Yes, so why don't you stop share? We can see everyone. And we have time for some questions. You can either raise your hand, unmute, or you can put those in the chat as well. So thanks so much for helping set the tone out of the direction of why we're here.
any other questions?
For both of you, I actually wonder, how do you typically get the information out to providers? Are there a number of ways? Like, is it typical for providers to have a sense of what survivorship is looking like in the state or not?
So first of all, we're using various sources of data, including some that aren't ours, some from the behavioral risk factor surveillance system. So I think the avenues by which the information is disseminated vary. To be honest, I think there are not as good communications with physician groups than there could be. And so I think, whenever we talk about cancer screening, for example, in Idaho, our cancer screening rates are among the lowest in the nation, and often providers are surprised to hear that. So I think we could probably do a better job with that. What we do though, is we have a website that has annual reports, has geographic specific reports like county cancer profiles, and a host of other information. And Bozena, you have anything to add?
Just that very little of that information is specific to survivorship. I think this is an area that we are identifying as being of higher need for us or higher utility for our partners in the state. And so I think we'll probably be generating more standalone reports and things like that that can be disseminated. But otherwise, this is it. This is the primary avenue by which we have shared survivorship information so far. And I see that Sam has a question.
Yeah, thanks, Sam.
Hey, thanks for putting that all together, and really appreciate you guys having that data available. I was wondering, the decline in the pre versus post-pandemic liver disease, did you guys get any insight into maybe what was driving that? I thought that was sort of an interesting finding anecdotally.
Right. And that's a great question. So competing risks of death is what it comes down to. The cancer survivors died of COVID at higher rates, and some other causes of death. So I just showed you like a tiny piece of the non-cancer deaths. I need to show you kind of all of the different competing causes of death for it all to make sense. So excellent question.
Appreciate it. Thanks.
And then we had another question in the chat from Katie. So you mentioned data on squamous cell carcinoma that isn't collected. Can you speak as to why those aren't tracked?
Yeah. Well, I think one of the primary reasons, two primary reasons. One, they have a very high incidence, and so the burden on cancer registries would be enormous. And then second is that they have very low sequelae and mortality, associated mortality. And so from a public health or clinical standpoint, I think the registry community has kind of decided that they're of less burden and potential importance. And so the trade-off between, burden and collecting and what we're able to say clinically or from a public health standpoint, the juice is not worth the squeeze there. Would you
Yeah.
go ahead?
And we did not make that decision.
Yes, also true.
So this came down from national partners at the CDC and National Cancer Institute.
Mhm. You can stand.
This is maybe a basic question, but in hospitals, clinics, how does the information get from really what happens with patients to you? Like, is it all through coding or does it come other ways?
That's a great question. When you say coding, so what happens in most larger healthcare facilities in Idaho and elsewhere is that there are hospital-based cancer registries. And so they have a team of people abstracting information, identifying reportable cases, abstracting that information, and then sending it to the Central Cancer Registry. And that is largely a human-driven task. Um, and then for smaller hospitals, the Central Cancer Registry actually abstracts those tumors in the same way that we would at a larger facility. So that's the primary mechanism by which the cancer data come to the Central Cancer Registry. And then we do probabilistic linkages with the Bureau of Vital Records and Health Statistics, as well as the National Death Index to identify, very, very long-term vital status for the people that are in our registry. We also do linkages or identify, I should say, area-based characteristics like poverty, percentage poverty in a census tract and things like that based on patient residency at time of diagnosis. We do some linkages with genomic data. There are a lot of additional linkages, but I think the primary mechanism by which we get information is from hospital-based or Central Cancer Registry-based registrars. And those are called oncology data specialists, and it's a certification through a national body.